Hi, I'm Dr. Randy Martin. We're here at the AATS Mitral Conclave 2017. I'm joined by my friend and esteemed colleague, Dr. Robert Dion, and he just won the Conclave Career Achievement Award, the Achievement Award. Congratulations.
Thank
well
you.
deserved, well
Thank
deserved.
you.
So, Robert, tell me, where do we stand with our knowledge about how to surgically treat secondary mitral regurgitation?
Well, it's still a controversy because first we have to make a difference between the real ischemic mitral regurgitation where revascularization is possible and the ischemic mitral regurgitation with a bad ventricle with no effective coronary revascularization possible. And in the first one, we can count on the revascularization to improve the left ventricle contraction. And then you can further think that you can treat that with a simple restrictive mitral annuloplasty. But if you are above 65 millimeters of end diastolic diameter and you do not have the possibility to revascularize effectively the ventricle, then you should really think about being inventive and work on the subvalvular apparatus, either replace the valve.
Robert, and if you have a non-ischemic, I want to come back to the ischemic in a second, but a non-ischemic secondary MR, is the size still the big determinant?
The size is certainly the big determinant, and of course, if you are borderline, let's say 67 millimeter, I think you need a magnetic resonance imaging to understand the amount of fibrosis in this ventricle.
Okay, interesting. As the ventricle gets bigger, you get more of the problems with tinning and restriction of the leaflets and all those things. But you said, why do you need to know about fibrosis in that ventricle?
Because if the ventricle is fibrotic, I mean, the chance that is going to carry on dilating, to persist in dilatation is present. And then if you do, in this case, restrictive mitral annuloplasty, you have the chance of a recurrence of about 30% after 6 months.
Okay, that's interesting. What about the question of the ischemic the akinetic or dyskinetic posterior basal aneurysm, okay?
Well, this is a very important point because the patients having important basal dyskinesia have not necessarily a bad ventricle. So in this particular patient, it is really even more needed not to replace the valve on the condition that you can repair this basal dyskinesia. And this is not so easy because sometimes you do not see from outside.
Right.
Sometimes from outside you see a quasi-normal muscle in the ventricle. So it takes some courage to go and incise in a normal muscle because you know that under there is a basal akinesia. If you are really doubting about reaching this aneurysm because it's probably too deep, then I think it's better to replace the valve.
Okay.
And we designed an operation to resuspend the papillary muscle, but not putting a cordae on the tip, but just resuspending the base of the papillary muscle with a very tight patch of Dacron to the annulus of the mitral valve. And then you re-anchor the posterior papillary muscle with the annulus of the mitral valve, and you correct, and you not only you prevent aggravation, but you correct the deformation.
What about the case, the common case, patient undergoing a CABG, and they have moderate mitral regurgitation in the operating room? What do we do in that situation?
Well, this is a very important question because there is no definition of moderate or severe mitral regurgitation without a stress test.
Right.
Ideally, the stress test should happen before the operation on a bicycle. But if you don't have that and you are confronted with a patient in operating theater coming from elsewhere who has no effective cycle test, preoperative bicycle test, then you can do it in operating theater by filling rapidly the patient through the aortic cannula, measuring the pressure in the pulmonary artery with the Swan-Ganz and looking at the echo. And if it's increasing from moderate to severe or from grade 1 to grade 3, then you should do something. Because another point is that why is your question so important is that some patients, they have preoperatively, let's say, grade 3, and after induction of the anesthesia, the
goes
grade
to
3
sure,
becomes
absolutely.
grade 1.
Yeah.
And then at that moment, you have really to do a stress test to know whether you should do something or not.
Final question. What do you think the role is going to be for the transcatheter mitral valve replacement, TMVR, in secondary MR?
The pressure is going to be enormous on the colleagues still wanting to do the mitral valve repair, because of course the mitral valve repair, certainly if it's a complex type of mitral valve repair, is going to be much less appealing for the surgeon or for the cardiologist than just blowing a new valve inside in the mitral position. So I think we will have to defend the advantages of the repair even more strongly than now. But I believe that the replacement is going to be so easy that we will have to defend the candidate for a repair more forcefully than now.
Excellent, excellent. Listen, congratulations again on getting the Conclave Achievement Award and for being the lead, almost the lead geese in the flight of geese.
Thank you very
You've
much.
led us along on this, on great knowledge. So thanks so much, Robert.
Thank you.
Good to see you again.
Thank you,
Thank you for joining us. Come back.